The lecture today is called Keeping Your Pain in Check, and we are very pleased to have Dr. Nicole Matar, who is a pain specialist at the Valley Hospital Pain Center, to present today. Dr. Matar, feel free to take it away, and thank you for joining us.
Thank you. Thank you guys for having me. I'm basically going to go over some of these slides, but hopefully more just talk to you guys at the end for questions or answer any questions regarding pain management, what the specialty is, what patients out there are suffering with, and how we can best kind of manage pain, whether it be acute or chronic, and how we can prevent it, from getting worse or even coming on. So, first things first, as we said, I am one of the physicians at the Valley Institute for Pain. We are located in the Lookout Pavilion, which is in Paramus. It's going to be across from the new Valley Hospital. We are a dedicated group of physicians trained specifically in chronic pain, but also managing some acute pain. We have a facility here with standard patient rooms, so we see patients in the office, and then we also have a procedure suite in the back where we do procedures as well that I'll touch on. We have nurses here. We have an NP as well, or nurse practitioner who also sees patients. And this institute here has been present for quite some time now. I'm newer to the practice. I joined over a year ago, but Dr. Thompson and Dr. Iverson have both been here for a long time doing this. And there are a lot of patients kind of established who come fairly regularly just for checkups to make sure that, they're managing their pain as best as possible. The types of pain that we see generally, this is obviously a brief list, but it branches out much bigger than this, but generally chronic back and neck pain, which is very common, joint pain, whether that be your knee, your hip, your shoulder, nerve pain. Some people can get that after shingles or sciatica or after surgery. We see patients who have cancer pain, abdominal pain for any reason, pelvic pain, etc. But these are kind of the primary types of pain that we tend to see here. I just put this in here. The medical definition that we usually go by is an International Association for the Study of Pain. And they define pain as an unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. All that being to say, I like to focus on the sensory and emotional experience. We focus on the fact that pain is subjective. It's not like anything else. When you go to another doctor, they check your labs and they try and get you to a target lab. But for a doctor in pain management, when we're working with our patients, we're really going off your emotional experience and what you're feeling. So the relationship is very important, and it's important to kind of work with someone to kind of express how bad the pain is. It's not always on a scale of 1 to 10, but it's how it's affecting your life and how it's affecting you kind of completing your daily tasks. And that's really what we try and focus on here. Chronic pain is that pain which lasts for longer than 3 months, which is mostly the case for lots of things, especially back and neck pain. Again, these are just like a bit of wordy slides, but they're all to say that chronic pain it's described generally as a disability that causes emotional disturbance and social withdrawal. So these things are really multifactorial, and you need to undergo, not just medication management and injections, but it's a whole kind of social upheaval of how you need to live your life. You learn to live with these chronic pain symptoms, and it requires biological, psychological, and social treatment. So it's not just one size fits all for everybody. The CDC reports that an estimated 50 million Americans, just over 20%, have some form of chronic pain. So it's actually very common to have pain. People, I feel like, try and grin and bear it or don't talk about it as much, but it's very common to have chronic pain. And people tend to seek medical attention for it with their primary care doctors and don't realize that there are pain management specialists out there. I'll be honest, even when I went into medical school, I didn't realize that pain management was such a big field, but it is a field, and it's growing. And, there are new and different ways to help pain. Pain management is in the news, and it's in, TV and books all over the place. People talk about the opioid epidemic, and I think that's a big reason that a lot of patients have a fear of going to pain management. They think that if they see a pain management doctor, they're just going to get pills and pills and pills, and they don't want to feel loopy. And we totally agree with that. Pain management started in one way, and it's really, really growing and changing to involve a lot of different things. It's not just, throwing pills at the problem. We don't want to just increase opioids and opioids. We actually try and avoid them as much as possible unless they're indicated for the situation that you're in. We try and do a lot of other things that will help you manage your pain in the long run. And again, this is all to say that pain management obviously has been going on for ages. People have been in pain, long before the 1600s, but in the 1600s, they first started giving opium to relieve pain or addressing the fact that it was kind of a medical issue. And then the field of pain didn't really come about until about the 1960s. So it is a newer field, but it is growing substantially. And because it's a newer field, it's something that's constantly changing, and new medications and new discoveries are being made, which is the good thing about it. I'm going to move past the opioid epidemic. Like I said, it is something that's out there. It is a problem that happens in a lot of practices. Physicians aren't used to prescribing opioids in a safe way. Previously, they were thought that if you gave opioids out, it didn't matter what the dose was. There was no side effects. And now, obviously, we're learning that there are side effects that come across with it, and it's become a big issue across the country. So it is important that if you do require pain medication, you're with a provider who is well trained in how to prescribe them and manage your symptoms and side effects. And this is just a brief, you don't even have to see the words on here. This is just a list of medications that we use that are not opioids. So it's just to show you that there are a lot of options out there, and patients don't realize that there are a lot of medications that we use for pain. In terms of non-opioid medications, again, these are just a long list. I'll just flip through them. We have anti-inflammatories, acetaminophen, local anesthetics, topicals like Voltaren cream that you might see commercials for. There is antidepressants that we use for pain medicine. There are anticonvulsants or anti-seizure medications that we use. We use muscle relaxants. Medical marijuana is kind of entering the space as an option. Now with marijuana being legalized, a lot of patients come in and say they're using CBD cream or THC cream. There is a time and a place. So we do also use the opioids when they're indicated. And again, that's kind of what we're here for, to help guide patients and other doctors out there to know when it's best to use them, when it's, not indicated to use them. But even amongst the opioids, there's a ton of different ones, and some work for some people and some don't work for some people. So pain management ends up being a lot of trial and error, and it does take a lot of time to find the right combination for any particular person. But more than that, there are so many things that are really important to pain management outside of medications. Studies have shown that physical therapy is really one of the mainstays of treatments for most chronic pain and acute pain. For most pain syndromes, physical therapy can really be beneficial. And patients tend to think that maybe it won't be helpful, or they try 1 or 2 sessions when the pain gets worse and not get better. But it's really shown that if you do it consistently over time, you help your pain syndrome and you prevent pain from worsening. These pictures below are from the lovely MAWA Health and Wellness Center that I believe we were all supposed to be at today, but unfortunately cannot be at, so we continue Zoom. But physical therapy is really, really important. We give referrals to physical therapy all the time. It helps you increase your flexibility, your strength. And after a while, eventually you can self-direct yourself. It motivates you to feel comfortable and to know what you can and can't do, and how you cannot injure yourself in the gym. We usually recommend an intake assessment, and then usually 8 to 12 physical therapy sessions over the course of 4 to 6 weeks. And that is really the minimum amount that I will recommend before you really start to see good results. So you really do have to go consistently to see these results. But when you're there, they can try different things for you: stretching, manipulation, hot and cold applications. Some people will do traction. They use the stimulation machines. But each physical therapy session will be tailored to your needs. There's also therapy and complementary and alternative medicine. These are also really important aspects of pain management that are out there. So like I said, pain really is defined medically as an emotional experience. So cognitive behavioral therapy, mindfulness, stress reduction, psychologists, therapy sessions, they can be really, really beneficial in pain states. And people, I think they get a little nervous when I say, do you want to speak to a pain psychologist about this? Because they assume that I'm thinking their pain is not present, that they're making up their pain, and that's not the case at all. The receptors that sense pain in our bodies are also the ones that sense anxiety, depression, everything is interplayed. Stress is related to inflammation. So therapy can actually be extremely beneficial for a lot of chronic pain patients. And then there's alternative medicine, acupuncture. Acupuncture has been shown in multiple studies to be beneficial. Dr. Iverson here at our practice does acupuncture. And we say you need to try at least 6 sessions to see the benefit of that. So it's something you really need to give a try. A lot of people will say, I did it once or twice and I didn't feel a difference, but it helps a number of pain states. It can help, with chronic back pain. It can help the peripheral neuropathy. It can be really beneficial. There's manipulation techniques. So our physical medicine and rehabilitation guys like Dr. Nunziato in the Ridgewood office will do osteopathic manipulative therapies for different types of techniques. Vitamins and supplements can be recommended. Oftentimes, based on your labs, I'll try and look and see if there's something that needs to be supplemented that you're not taking. Things like yoga, music therapy, we really try and make it very all-encompassing. These are the types of things that actually really make the difference in your pain. Acupuncture, we talked a little bit about, but studies have shown benefits. Like I said, it's traditional Chinese medicine. They stimulate specific parts of the body through the use of needles. It's been used for 2,000 years in China. More recently, now they use electrical currents. They can stimulate the needles. They do electrical acupuncture. And like I said, it's used to treat a wide variety of pain syndromes. And then we also have interventional procedures. So there are injections of local anesthetics and steroids. I'm sure a lot of you out there have had a steroid injection into one joint or other. It's fairly common. Other peripheral procedures, electrical stimulation, and of course surgery, which is the thing we're usually trying to avoid. We do trigger point injections right here in the office. That's a little bit of dry needling into the muscles that may be spasming or maybe tight. We can put some local anesthetic or lidocaine and steroids into those muscles. And that can be really helpful for neck, back, buttock pain. A lot of patients get pretty good relief with that. It can last anywhere from 3 to 6 months. Obviously, that's a bit of a bell curve, so it's very variable person to person, but a fairly safe injection that we do right here in the office that a lot of patients get a lot of relief out of. Joint injections, your orthopedic will do these. We will do these in your knee, in your hip, in your shoulder. We will use an ultrasound, we'll use an x-ray, or we may just use landmarks on your body to figure out exactly where we need to go. And these can be very beneficial and can help stave off surgery, or if you're not a surgical candidate, it can sometimes help kind of just at least take the edge off. There are peripheral nerve blocks, which is a similar concept where you numb the nerve that's causing the pain. That can be useful for headaches. It can be used for knee pain, back pain, facial pain. There are nerves all over our body. They're innervating every piece of our skin. So if something's hurting, there's probably a nerve that we can find and block it most of the time. Block it, meaning numb it, to help you with the pain. And again, they're temporary procedures, but at some point, they are band-aids to help you get to physical therapy and get to do the other things in your life. And, it's a way to stave off surgery or more invasive procedures. There are implantable devices like peripheral nerve stimulators, same thing, where they temporarily are placed in your body, can stimulate the nerve and then be removed. And that's thought to somehow rewire your brain so that you no longer feel that pain, even without the device in the future, similar to a TENS unit, but somewhere that's implanted into a nerve in your body. Sympathetic nerve blocks are another type of nerve block that we do. The injection risks are very, very rare. We generically say bleeding and infection for everyone, an allergic reaction, but they're not common side effects. They're dependent on which surgery you're getting and where you're getting that surgery. So the most common complaint by far is back pain. 65 million Americans have reported some kind of recent episode of back pain. 16 million adults experience persistent or chronic back pain. It's the 6th most costly condition in the United States. Healthcare costs and indirect costs are over 12 billion per year. It's the leading cause of work loss days. It affects all adults of all ages, all incomes, and earnings are lower for workers with back pain, obviously because it's limiting the time they're at work. So spinal injections are very, very common, whether they be in your neck, your mid-back, your lower back. And there are different types of back injections. There's more than just the epidural. Commonly, patients will come in and think the epidural is the only option, but there are other back injections that we do as well, always under x-ray guidance. based on your MRI imaging, if all else fails, we'll usually try an injection. We usually say you try at least 6 weeks of conservative therapy, which is physical therapy and medications. And if really nothing is touching it, then we can always try an injection. And like I said, epidurals seem to be the most common, very common for disc herniations or spinal stenosis. We always use the X-ray machine, so it's a safe procedure. We know where we're going. If you're on a blood thinner, those do need to be held. We usually get clearance from your cardiologist beforehand, and there's pretty minimal side effects. It's not under anesthesia. You're awake when you get them done. You drive yourself here, you drive yourself home. No real limitations from the procedure. We have another injection called a facet injection, which is again a back injection. The good thing about this injection is there's an option for something longer lasting called an ablation, which is really like a cauterization or a burning of the nerves in your back that can give you longer lasting relief. So people can come get those, every 6 months or every year, rather than coming for repeat steroid injections that don't last as long. And that's what I was just talking about, the ablation. So it's a cautery of the nerves in your back, and it can last a little bit longer. So we do have some longer lasting options, a little bit more invasive, but again, here done in the office, awake, no restrictions. You drive yourself here, you drive yourself home, and fairly safe and quick. There are more invasive procedures, and this is really only comes once you fail all the conservative therapy. So I'll just kind of brief over them. Spinal cord stimulators are implantable devices that can help with chronic back pain that's failed everything else. This is our procedural suite. We have the pain management suite. We have you come through the door here in the back. And this will be the preoperative bay where you would wait and talk to a nurse, and you would tell her all about your symptoms. We'd confirm that everything is consistent with the injection that you're getting, make sure that you held your blood pressure, that your blood sugar was in control. And this is the procedure room, just a table and an X-ray machine. So you usually come and you lay on your belly. We take some pictures of your back if it's a back injection. Obviously, if it's a hip or whatnot, you'd be in a different position. We take some X-rays, do the procedure in about 10 minutes. And then you go back to the recovery room. We watch you for a little bit of time, make sure everything's okay, and then you're on your way. So the goal, we like to use the word multimodal analgesia. The goal is to use a mix of everything. You don't really want to just stick to one thing, and one thing often doesn't work. There's no one size fits all. There's no one pill that works. If there was a magic pill that fixed all of back pain, then I would be out of a job, but 60 million Americans would feel much better. So that would be fantastic, but we don't have that, unfortunately. It requires a lot of provider communication. It's not just us, but we refer you to neurologists and rheumatologists and your orthopedics, your physical therapists, your chiropractors. I'm always getting paperwork from the physical therapist to confirm that what they're doing is appropriate. We're always talking to each other back and forth, thinking, can you get another set of eyes on this? Is there something else going on? All the doctors really need to work in communication to help you with your pain. And then before all this, so, if a patient comes to us and they've had pain and their pain is alleviated, but they want to talk about how to prevent it. That's a common occurrence. Patients like, I made the appointment and now all of a sudden everything feels better. I'm here on the day of the appointment, but I didn't want to cancel it because now that I'm here, what can I do to feel better? And it's all things that are probably, easier said than done, and things that we know deep down, but we need to be, reminded of. Regular activity, low impact aerobic exercises, building muscle strength, flexibility, maintaining a healthy weight. Losing weight is, a common recommendation always. Quit smoking. All these things really do affect our pain. They affect inflammation in our body. Avoiding extended periods in one position. We're very commonly sitting all day long at a computer. You have to get up, you have to take breaks. And then you have to lift smart, using your legs, not avoiding all these heavy objects or lifting heavy objects if you can. Obviously, sometimes someone's job really precludes them from some of these, but it could be helpful to go to physical therapy to learn how best to do it. How should I be lifting this object? What should I be doing to help myself? So what would you expect if you came to pain management? We would start by just asking you a million questions. I'm going to ask you, where is the pain? Does it travel? When did it start? How often does it occur? Can you describe it? And I usually throw off a million different words like sharp, stabbing, shooting, pinching, burning. The patient gets overwhelmed and has a tough time describing it, but any kind of description that you can do, what makes it worse, what makes it better. We commonly ask the pain score on a scale of 1 to 10, 10 being the worst pain in your life, which is really a very hard question to ask. But, it's so subjective. We have no real way of knowing otherwise. So we try our best with the words that we have to figure out what you're feeling. And then, there are charts in our office to help us, figure out what's going on with you. Where on your body is the pain? Can we tie it to a certain nerve or a certain treatment that would be helpful for you? We'll ask about what medications you've tried. Have you tried anything in the past? We'll talk about all your other health problems. What problems are, going to be a contraindication to an injection or a medication? What of your medications could be affecting your pain? It really is a big review of, all your well-being when you come to the office here, because pain, like I said, it's not just you bumped your toe and the toe now hurts. It's a lot of things. Pain gets worse when you're stressed, or if you have other things going on like smoking or obesity, that can make the pain worse. We'll get x-rays, we may get MRIs, labs, we may send you to a different doctor, and then you make the plan from there, basically. We'll do a physical exam. Oftentimes you'll come here and we'll have you walking up and down the hall. We want to see how you walk. We want to see, are you swollen? Is there redness? We'll check your reflexes, your sensation. We do all these special tests just to figure out what's going on. And then, I'll talk to you about what we think the pain is. It could be many things. Sometimes I'll say I have no idea. I don't know what the pain is from, and we'll have to figure it out. We'll have to get more imaging, send you to more doctors. We don't always have the answer. And even after we do a big extensive workup, sometimes I still don't have an answer, but that doesn't mean you don't have pain that doesn't need to be addressed. So, the point of the consultation is to plan. We want to figure out what preference you have. Are you someone who would prefer medications and are scared of needles? Are you someone who only wants to get injections and doesn't want any medications? Are you someone who just wants to talk to me about, getting to physical therapy and trying vitamins and trying a conservative treatment? All these things can be discussed in an office visit here. And then even, not even at the office visit, just on your own, things that you now know to do or to look for. If you know an acupuncturist, you've driven by a place a million times, maybe now you'll try it. Or if you have never done physical therapy or you've only done 2 sessions and it hasn't been helpful, hopefully now maybe you'll go for a little bit longer, because the studies show that you should go for at least 6 weeks. And then, of course, if all else fails, all we're trying to do most of the time is stave off any kind of surgery. If you have severe bone-on-bone arthritis or you have a compression fracture in your back, at some point, there's only so much we can do to mask the pain, and we do just try and find the right person for you to see. And that is basically it. I hope we have some questions.
Okay. Hear me okay, Dr. Matar?
I do.
Yeah. Just a couple of questions, one of which is interesting. Just what are the general feelings about the like the opiate crisis and the post-opioid world at this time? I know that there's sort of been this kind of back and forth. Obviously at one point those meds were given way too liberally, and now there's quite another thing going on. So just want to get your ideas.
Yeah, and no, it is very complicated. It's become complicated. It's a legal, ethical, medical issue these days, and the guidelines are always changing. So, guidelines that I previously said just escalate the opioids until you get pain relief are now saying minimize them, really only use them acutely unless a patient has failed multiple therapies and there really is no option. Cancer pain obviously is an indication to be on these chronic opioids. But it's a person-to-person situation where you need to evaluate, is this the safest drug of choice? Is there any other option that we could do? Are you having any side effects from this? Regularly monitoring it. It legally can only be prescribed in short intervals if you're not a pain management doctor. So your primary care doctor may no longer be able to prescribe you a month at a time that they were previously able to do. It requires regular drug testing, which we do here in our office. That's a legal New Jersey mandate that patients, I think, often get surprised by, but we do need to drug test you to make sure there are no illicit drugs in your system. It's a pendulum that swings back and forth where you don't want to give too much and you don't want to withhold it from people who really need it. So it's a tricky situation, and it's very person to person. You know, in pain management, it's not like other doctors where you'll go and see 1,000,001 pain management doctors and get 7 different, opinions on the situation, because you don't want to get opioids from multiple providers. That's can obviously cause confusion and cause overlap of medication. So it is a complicated process that you have to kind of work out with your doctor slowly, it takes a long time to find the right regimen for you. And there is a time and a place for their use, as long as they're done safely. But it does require more monitoring than we had thought in the past, where, you'd leave from a tooth surgery and get 300 pills of medication. That is not the appropriate way to do it. And I'll often hear from patients who say, oh, I found these, pills from 3 years ago in my closet and my shoulder was hurting, so I took it. And I understand their pain and they wanted to try something, but that having that many leftover pills is not what we want out there. There's a fear of people stealing it, who come into your house, and etc.
Right. I would imagine mental health may come into play here too. That's something you've got to be very, very well aware of, like you said. That's important. Have you noticed, has there been any changes post-COVID? Have people could be coming in with any COVID-related issues or any of those? Mm-hmm.
Yeah, I mean, I don't think there's literature or studies on it, but just anecdotally from what I've seen, it's most of my patients, or patients that I've seen already with chronic pain, will have a bout of COVID and make a follow-up appointment immediately after they get over it, because all their pain has worsened. And there have been some situations where a patient had COVID who had never had pain before, has some, inflammatory pain, whether it be joint pain or this or that. But we are definitely seeing an uptick in pain, chronic fatigue, chronic headaches. These things are definitely being seen.
Yeah, definitely hasn't had an impact. Someone wrote, do biologicals like Cimzia help with pain from fibromyalgia and arthritis? Is that something you've seen?
Yeah, so the biologics can be fairly beneficial. We usually refer or defer the biologics to the rheumatologist. So that's exactly what I meant by, interdisciplinary, multimodal. So, if I see someone who might be a good candidate for a biologic, I'll usually refer them to a rheumatologist. They'll manage the biologics. We'll try and manage the other medications and find the right combination for you. They have been shown to be beneficial, but I am not usually the prescriber of the biologics. So I'm not 100% up to date on the exact benefits of them, but we definitely send you to rheumatology to discuss those issues with people.
Great. Is there anything on the horizon that you're aware of regarding the future of pain treatment? Anything?
It is not. It's funny, I just said this to a patient today. It is not moving as fast as one would think when there's so much pain out there. Like, it is crazy to me that we don't have a great treatment for sciatica. We try the injections and the medications, but everybody has probably complained of sciatica at once in your life. And the field isn't moving that fast. There are, newer procedures that are starting to get out there, PRP therapy, which is, using your own blood products and injecting them back into your joints. Things like that are trying to kind of make their way into the horizon. People are really focusing on interventions, injections, because they're really considered pretty safe. The steroid load is pretty low and patients do really well with them. Even though they're temporizing solutions, I mean, you can technically get them, for all we know, for several years. So a lot of people are focusing on the injections pretty heavily, rather than, being tied to a medication every day for the rest of your life. But there is nothing specifically that, I'm like on the edge of my seat for. I will say VR therapy is something that I have heard. Virtual reality, basically like putting a headset on and distracting yourself from the pain, because distraction techniques are a big thing. So I think that will be something that actually comes into play at some point.
So interesting. Yeah. So someone had just one more question. Is it safe to take Tylenol and Advil for an unlimited amount of time for pain? If not, what are the recommended? Are there any time constraints on that?
Yeah, that is a question that needs to be kind of tailored to the patient. It would depend on their kidney function, their liver function, any gastric side effects, history of blood clots. Both those medications can have some of those side effects. So it really depends on the person. Tylenol, the maximum recommended dose is 1,000 milligrams 3 times a day, or 3,000 milligrams maximum in a day. It had previously been 5, and then it was dropped to 4. And then in the last few years, it's been dropped to recommended 3,000 to avoid any liver dysfunction. And it's thought now that you can take 3,000 daily regularly for an extended period of time. I don't know that anybody's put an end date on that, but that is considered to be fairly safe as long as you're taking under that 3,000, under or equal to that 3,000 a day. Ibuprofen, the anti-inflammatories, they are a little bit more tenuous in the sense that they can increase your blood pressure, they can increase your risk of blood clots, they can cause gastric upset. So we tend to not recommend taking those for extended periods of time for, the rest of your life daily.
Sure. And somebody's asking about physical therapy. Is that a good place to start for managing osteoarthritis pain in the knees and lower back?
Yeah, it's,
Mhm.
Oh, go ahead, sorry.
No, when blood pressure meds prevent the NSAID rule, like, NSAID can be problematic for certain people. So is that a good place to start physical therapy?
Yeah, NSAIDs can be very problematic for, I would say, most of the providers. Anybody on a blood thinner, or patients, anybody on blood thinner, people with high blood pressure usually should be limited with the anti-inflammatory. So, first step, mainstay of treatment in every single study that's been done for pain is physical therapy, and it really does help. I say that though in the sense that people will say I went to physical therapy and my pain was bad afterwards, but that's to be expected. If no one works out for a year and then they get up and they try and run on the treadmill, it's going to hurt everywhere. So it can sometimes get a little bit worse before it gets better, but we usually recommend that, again, tailored to the person. If you have bone on bone arthritis, it does become a bit of a surgical issue at that point. Physical therapy will do the best they can to strengthen your muscles, to offload that pressure on your bones, and they'll help you kind of learn not to make the problem worse, but it may not be better in fixing the pain from bone on bone issue. So everything has to be tailored to the situation.
That's great. It's good to hear about acupuncture being something that's fairly readily used. And I'm sorry if I missed this. Has there been any literature or have you guys been involved with any kind of cannabis, using cannabis at all, or is that something that's happening?
Yeah, so the medical marijuana has definitely come into play a little bit more. The literature has waxed and waned quite a bit. So it was very popular for a while to minimize opioids. Now they're finding that it may not help as much with that physical pain as it does with the anxiety component around pain. So there's definitely a place for it. We are all certified to dispense medical marijuana. We certainly reserve it for certain types of situations and kind of assess each person patient to patient, but there's definitely a role for medical marijuana in someone's pain management.
That's good to know. Great. Well, thank you so much. This was really informative. Thank you, everyone.